So good evening, ladies and gentlemen. Welcome to this fourth meeting on our little series on health. Tonight, I'm quite happy to welcome Professor Kirsten Ostherr from Rice University in Houston. And I'm particularly pleased because this was my own university I hardly dare say it, in 1988. That was quite a while ago. Professor Ostherr is the Gladys Louise Professor of English. She is the departmental chair of the English department and the director of medical humanities. And I'm quite interested in hearing what all this implies, what medical humanities implies. Rice University is in Houston, Texas. Professor Ostherr is a media scholar, health researcher, and technology analyst. Her research on trust and privacy in digital health ecosystems have been featured in Slate, The Washington Post, Big Data and Society, and Catalyst. She has recently published research on medical humanities and artificial intelligence in the Journal of Medical Humanities, and her writing on COVID-19 has been featured in Inside Higher Education and in American Literature. She is currently leading various projects. What is interesting is that she is the founder and director of the Medical Humanities Program and the Medical Futures Lab. Perhaps, Kirsten, you can elaborate on that also a little bit later. The Medical Futures Lab is a collaborative center bringing together faculty from Rice, Baylor College of Medicine, and University of Texas Health to reimagine medicine at the intersection of humanity and technology. So medical humanities tonight. Kirsten, you have the floor.
Okay,
Welcome.
Thank you very much. Thank you. I'm delighted to be here. I'm going to go ahead and share my screen to get started. Let's see, do you see my slide?
Indeed, yes.
Okay, yeah. Wonderful, perfect. All right then. So thank you again. Special thanks to Dr. Bruno von Lutz for the invitation to speak to you today or tonight for you. I'm really honored to be here, and I'm delighted to talk to you about the medical humanities, what they are, and specifically what they can teach us about the kinds of innovation that occur in times of crisis, specifically COVID as a crisis, but I will broaden this out to other ongoing crises, including the environmental crisis towards the end of my talk. I want to talk in particular about the kinds of innovation that the COVID-19 pandemic did and did not accelerate, particularly at the intersection of humanities and health technology. I think that we can find important lessons to guide us forward as we continue to address the complex global crises of human health, which are only compounded by environmental degradation. And these crises really demand collaborative, multidisciplinary approaches, such as those that I will discuss with you today. So earlier this summer, I was in Berlin to celebrate the first annual Benjamin Franklin Day at the Benjamin Franklin campus of the Charité Hospital. And I want to start with a little bit about this figure, Benjamin Franklin, because his history connects to the story of medical humanities and health technology innovation that I would like to tell today. Benjamin Franklin was known to be a prolific writer and inventor, and one of his inventions was what we would call today perhaps self-tracking. In his efforts at self-improvement, Benjamin Franklin devised a list of 13 essential virtues, and he created a formula for monitoring his progress in achieving those virtues. And you can see his 13 essential virtues on the slide listed here. Here you see a sample page from the template that Franklin created so that he could annotate his progress on a daily basis. His method was to devote himself to pursuing one virtue at a time for a solid week and documenting his failures, not his successes, but his failures in a notebook before he moved on to the next virtue. So in this example, you see this is a page, this is a week where he's monitoring temperance. Eat not to dullness, drink not to elevation. So this is a version of what we might call today self-tracking, manual self-tracking, analog self-tracking. In his emphasis on failures, I think Benjamin Franklin perhaps anticipated some of the sensibilities of the technologists of Silicon Valley in the United States, who today play an important role and have in recent years in developing the wearable sensors and mobile technologies that have made it possible for regular people to participate in modern forms of self-tracking by monitoring a wide range of physiological signals emanating from our bodies using devices like those that you see on screen: Fitbits, smartwatches, remote heart rate monitors, and more. Even before the pandemic, these innovative tools were pointing toward an extension of the spaces and practices of care that went far beyond traditional clinical settings. And these tools suggested a new role for individuals to participate in their own healthcare. The notion of a digital or quantified self emerged through the practices of self-tracking, lending credence to the idea that the social and behavioral data produced through the activities of 21st century daily life might contain health-relevant insights. One outcome of this development is what we might call the datafication of clinical and self-care practices, resulting from widespread personal tracking of behavior. Here you see some examples from the Quantified Self website, and the Quantified Self as it's understood to be kind of a set of practices, but it's also a specific website that is a group of people who gather and share their own self-tracking projects. And there are Quantified Self groups in cities all over the United States. But of course, the first one and the most active and largest one, not surprisingly, is in the San Francisco Bay Area, where Silicon Valley is. So you can see on the screen some examples from the Quantified Self website showing, for example, N-of-1 studies attempting to understand the role. One of these is the role of microdosing on mood, microdosing with psychedelic drugs, as well as efforts to predict the onset of influenza in pre-symptomatic individuals. That project goes back to 2016. We might ask how health is being redefined by these communities who pursue their own visions of care outside of clinical settings. And further, we might question how the proliferation of self-tracking data is opening up new possibilities, not only for self-knowledge, but also for corporate and state surveillance. The COVID pandemic radically expanded the actual and imagined need for digital tools that could accomplish the kinds of healthcare that previously had taken place in face-to-face medical settings. The turn to technological solutions during the pandemic was sometimes life-saving, to be sure, but some of the interventions that were promoted during the pandemic may have caused more harm than good. An important question that humanities researchers bring to bear on this topic relates to the missing context and the stories that the data alone cannot tell. For example, a study, which you see represented on the screen here, a study attempting to use smartwatch data to predict the onset of COVID-19 detected metabolic changes 3 days before any COVID symptoms appeared. But they were not capable of differentiating the signals of pre-COVID from signals that might just relay other kinds of stressors, other sources of stress on the body. The signals were essentially detecting a stress response in the body. And it could be a stress response to COVID, but it could also be a stress response to work, to caregiving, to financial strain, or exposure to racism, which was highly exacerbated during the pandemic. This is significant when we think about the unequal distribution of stress that different social groups faced during the pandemic, as well as the digital divide in technology access. And I wanted to show you also, this was something that came through my inbox just this morning from the Quantified Self, which is a presentation that someone did recently on using heart rate variability to reveal COVID-19 infection. So it's another version of that kind of study that I was just talking about. It's a very common kind of approach to trying to monitor your own signals and then understand what they mean using digital technologies. So I want to spend some time talking about what we can learn when we place these kinds of examples in a broader health humanities frame that might guide more balanced approaches to innovation when future crises come along. A key point that I think we need to take from these developments is that often the failures of technology are not about the technologies themselves. They're about the relationships of trust or mistrust among the people using the technologies and the data that they produce. So for example, during the pandemic, we have seen that tools such as digital contact tracing tools were developed and deployed without clear evidence of their effectiveness in reducing the spread of disease. Instead, digital contact tracing technologies enabled a level of state surveillance that exposed and in some cases exacerbated mistrust of government actions. This was especially true in the United States among communities such as African American, Latinx, and Native American communities who had long histories of harmful surveillance and tracking practices imposed upon them. This is an important example of a case where an attempt to develop an innovative and helpful approach to addressing the COVID crisis could have really benefited from more collaboration between technology developers and researchers who work on ethical and racial issues in science, medicine, and technology. These issues of trust have deep implications, especially when we think about the consequences of being included or excluded from the data sets that were used to understand and guide resource allocation aimed at intervening in the pandemic. And one of the images that you see on the screen right now, the photograph shows a headline, Native Americans being left out of US coronavirus data and labeled as other. That was reporting from early in the pandemic where there was no category for tracking Native American incidences of COVID infection. And as a consequence, as one of the tribal spokespeople stated in this interview, including us in the other category effectively eliminates us in the data. We don't exist for the allocation of resources. This was this problem of inadequate or even non-existent tracking of different racial and ethnic groups persisted throughout the pandemic. It improved somewhat so that we went from no tracking to some tracking, but we are still nowhere near 100% in terms of tracking racial and ethnic identity in COVID reporting or in other incidents reporting. For example, in the current monkeypox outbreak, there's a very similar problem that's occurring. So to focus on just one element of this issue of reporting and data and who gets represented, many people, many especially researchers and government officials, have seen and understood this pandemic through data visualizations. This image is of a dashboard from Johns Hopkins University that was widely seen and referenced, certainly in the United States, and I think in other parts of the world as well, widely used by news media, by policymakers, and as well by regular people who were trying to understand what was happening around the world and in their own location. If you're not familiar with this site, you could zoom in on a country and even on a city, excuse me, within that country. And it initially tracked cases and deaths and test results. And over time, this screenshot is from back in April of 2021, but now the site also tracks vaccinations and recoveries as well. This form of representation very much represents the pandemic through the lens of data, big data, and the consequences of representing the scale of the pandemic in this mode is something that I would like to emphasize in the remainder of my talk. This sort of view of the pandemic through the lens of data. Because we've been plagued by inadequate testing, especially in the United States, this has been true, but in many parts of the world, this has been true, as well as uneven attention to the effects of the pandemic on different groups, especially along racial fault lines, and that has left major gaps in the data visualizations. So this is an image of a testing site from Texas from early in the pandemic, May of 2020, and a report that talked about how in different Texas cities, access to testing may depend on where you live. And what they were trying to track was the extent to which testing sites were located in areas that were predominantly white or that were predominantly a different race or ethnicity or were more mixed. And they were finding that it was harder to get access to a testing site in areas that were not predominantly white. So as a media and technology scholar doing medical humanities research, the question of how visualizations, visual representations have shaped our understanding of the pandemic has been a critical question for me. And over the past 2.5 years, I've often asked myself versions of this question: how do the tools that we use to visualize the pandemic shape our understanding of the crisis? Another way of asking this question is, what do we see and what remains invisible when we look at a crisis through data visualizations? And importantly, how do the gaps in our view of the pandemic, especially those gaps that are gaps in the data that we have even been tracking, how do these gaps potentially lead to flawed decision-making that can exacerbate existing harms and even create new ones? So my research on the role of health data tracking in shaping our understanding of the COVID-19 pandemic has led me to conclude that data are always missing, messy, and provisional. And data scientists also often make this point. Nonetheless, the data visualizations have very much come to play a dominant role in shaping our understanding and policymaking. But because of this, COVID-19 makes clear that we must engage with data and data visualizations, both as sources of information and as central sites of ambiguity and uncertainty in public health and medicine. And that is an area where humanities methods and insights can really play a central role. So this brings me to a key point that I want to emphasize today. When we reflect on successes and failures from the pandemic and the lessons that we might learn from them, we can see that as essential and life-saving as scientific and technological innovation have been, their reach and efficacy are limited when they are used in isolation. Instead, we must take the human, societal, and cultural context of our interventions fully into account. For example, vaccines are only helpful if people believe in their safety and efficacy and are willing to use them. COVID prophylaxis and interventions once one is sick are only life-saving for those who have access to high-quality care. For this reason, I believe that we need to move forward with greater commitment to developing translational humanities methods for ensuring that we anticipate and address in advance the foreseeable challenges that will come with future public health and climate crises. So since around March of 2020, I've been working with a team of students, undergraduates, graduates, as well as postdoctoral fellows and other faculty members to identify and document what we are calling translational humanities approaches that transcend what I would consider the artificial divisions between medicine, technology, and the human sciences. For example, I discovered a project early on in the pandemic that was led by a professor named Russell Young, who is a professor of Asian American Studies at San Francisco State University. And he started tracking xenophobic anti-Asian attacks that were occurring in the early days, weeks, months of the pandemic. He started tracking those on a new website that he helped to launch that was called Stop AAPI Hate. And in the site's first 8 days, they received more than 650 reports of discrimination, often violent, against the Asian American community. And this was all very much being driven by inflammatory political rhetoric that was being used at the time about the origins of the pandemic. This project has, over the past 2 years, gained a lot of attention, including by the California State Legislature, which has now allocated over $1 million of funding to support the Stop AAPI Hate website, as well as their analysis and research. And I want to share a few other examples that I have found of translational humanities projects, as well as the work that we have done to gather these and represent them on a website. But I mainly want to emphasize to you what these kinds of projects look like and what they bring beyond the scientific and technological interventions. So the UN, for example, issued a call for creatives early on, saying that they need the help of creative artists to translate critical public health messages into work that will engage and inform people across different cultures, languages, communities, and platforms. And they recognized that to do so, this had to occur through visual forms as well as linguistic forms that resonated with people in different parts of the world that came from their communities. And so they sent out this call to people all around the world to submit artwork that could be used to publicize some of the key messages that they wanted to promote about ways to avoid COVID and to stay safe. These are 3 examples of the hundreds that were submitted. One is from Brazil, one from Belgium, and one from Panama. And these, many of these were used in public health messaging in these different areas to promote the key messages about COVID prevention and safety. I published an article in the Washington Post in March 2020, early on, that was building on previous research I had done on historical public health films to make the case to a wider audience that we need to recognize that visual narratives, including movies, television, TikTok videos, and internet memes, play a major role in shaping and perpetuating cultural narratives about why outbreaks happen and how to stop them. And I wanted to put this communication out there and this research out there because I was seeing a lot of similarities in media reporting on the early months of the outbreak that resonated very much with racist and xenophobic and harmful forms of representations from public health films dating back to the early 20th century. So I drew on that to try to translate some insights from the past to the present context. And similarly, there was a piece in Scientific American that noted, based on historical research on the 1918 influenza pandemic and the 2002-2003 SARS outbreak, noting that social distancing measures, communication, and international cooperation were found to be the most effective methods to slow those earlier outbreaks and would probably also have that effect in COVID-19. And I find this very notable because these are also, they're both well-known forms of intervention, and they're very inexpensive and readily available. They don't require advanced technology. The WHO has been running a series since 2004 called Global Health Histories. And the aim of this series is to understand the history of health through the lens of historical research that, again, is translated to help the global public health community respond to present day challenges. So it's a translational approach to the history of health and medicine. But there are some other projects that I found particularly compelling too that occurred outside of academic settings. And some of these focused on the places where there were COVID hotspots in the early times of the pandemic. And those included prisons, also factory farms, and nursing homes. And these projects, for example, the ones focused on prison data, on just documenting how many cases were occurring in prisons, which was information that was not easy to find. They really reframed these sites as, and the fact that these sites were hotspots as an expression of societal values. In other words, an expression of the kinds of moral investments that were made in either protecting or not protecting people in these different kinds of venues where they were being housed. Extending that idea, projects using contextual data science looked at not only sites of outbreaks like prisons, but also at the broader policies and values that created those hotspots in the first place, such as urban design that left certain populations more vulnerable to COVID, and that also leaves them more vulnerable to the effects of climate change. Other projects looked at data visualizations themselves, asking, how can we humanize the pain, suffering, and loss contained in the ever-growing numbers of COVID-19 deaths? This project, COVID Black and Homegoing, to me really stands out in contrast to, for example, the Johns Hopkins data dashboard, because COVID Black seeks to restore the humanity of the African-American lives lost in the United States by using images and narratives to represent each death. And so in this project, as compared to the Johns Hopkins data visualization, where you had just the representation of a global map and then red circles that represented how many cases there were in different parts of the world. So you got numbers, but you didn't know anything about who those people were, what their life experiences were, or how unequally the incidence of infection and mortality were across these different sites. Here, instead, what you have is you have a visual representation where you still see the scale in a way of the suffering by seeing all of the photographs and the names of those people listed alongside them. And if you were actually on this site, you could scroll down and it just keeps going and going. It's a long, long, long column of photographs and names. But then if you hover over one of these photographs, you see a pop-up like the one that is in the middle of the screen here, where you get a little story about each person, and it tells you about their life and the things that they enjoyed and the people that they left behind, perhaps. And these stories are all gathered on this site by Professor Kim Gallen, who is the lead on this project. They were gathered from news accounts, from obituaries, from social media, from other kinds of sources of information that were out there that had a more narrative approach to representing death from COVID. So seeing all of these kinds of projects, which again, I saw as translational humanities sorts of projects, I was really inspired to gather them together so that they could be available in one location, primarily because I saw that these sorts of projects represented insights about the kinds of harms and the kinds of interventions that were needed to address those harms that were not really very much being attended to by policymakers during the COVID pandemic. So as my team gathered more and more examples of translational humanities projects like the ones that I was just showing you, we started to collect them into a public searchable database that we called Translational Humanities for Public Health. And our aim was really to publicize and disseminate this work so that it could model methods for responding both to COVID as it continued to evolve, but also to other kinds of future crises. And as I mentioned, especially to intersecting crises between health and environmental crises. So in addition to the examples that I've already presented, many of the projects that I've just described to you are featured in our website, but I also would like to show you a few more projects that highlight the range of interventions that we've found, including some that are from Germany. And I hope that by seeing these projects, you will get a sense of the wide range of kinds of research that is being done in the medical humanities, especially to respond to COVID, but also the ways that these kinds of projects can actually be employed to address existing problems and to bring humanities insights in ways that that highlight certain aspects of the human experience that are not always attended to. So what you see here is a screenshot from the homepage of the project, from part of the page where we have tiles representing some of the different projects that are on the site. We have received over 350 responses to our invitations to contribute to the site, and we presently feature over 120 projects from at least 23 countries. So, for example, in this screenshot, you can see images from 9 sample projects based in Hong Kong, Luxembourg, England, Portugal, Germany, Chicago, New York, California, and so on. Some of the projects focused on healthcare settings, such as Frontline Nurses, which was a collection of oral history interviews with nurses and midwives that looked at their experiences during the pandemic. So these are people who were experiencing the crisis kind of upfront, and they were bringing their voices to share so that policymakers would have a different understanding, a more nuanced understanding, as well as other healthcare workers of what was actually happening behind the scenes. Because you may recall that early in the pandemic, hospitals, the media were not allowed into hospitals. And so there was a great deal of uncertainty about what was really happening and how people were experiencing the situation, especially in sites of hotspots. This other project, Jefferson COVID Stories, is a creative writing project by and for health professionals, where they have weekly writing prompts to help the community, as they say on the website, find the light that still shines amidst the uncertainty and higher demands placed on healthcare workers during the pandemic. I find projects like these particularly interesting because in the field of medical humanities, there is a tradition called narrative medicine, which is about understanding the importance of storytelling in medicine, both patient stories, understanding and learning to listen to patient stories as a part of the process of diagnosis and care. But also there has been a growing recognition, especially during the pandemic, of the need to bring attention to narratives of the providers, of the healthcare professionals who are taking care of patients, especially in the context of so much suffering and death. You have probably heard stories of how much burnout and exhaustion and despair and what is often called moral injury has occurred in the context of this pandemic, especially for healthcare professionals who have experienced circumstances that worse than any they have ever experienced before, and on top of which have in many cases had to do so in contexts where the general public may believe in part in misinformation about the pandemic and therefore may refuse to take precautionary measures that then ultimately results in more suffering and death that these healthcare providers see and care for and that they recognize as preventable. So that whole context has created a very difficult situation for people in this setting. And these are 2 projects that are using humanities methods, oral history and narrative writing, reflective writing and creative writing, to try to address some of these issues for the people who are experiencing them. Here are 2 more projects. One is called outbreakroom.org. It's a website that serves, again, as a virtual gathering place for healthcare workers from across the country. This is in the United States. As they say on their site, it is a place to decompress over poems, reflexive essays, and other pieces of art by and for healthcare workers during the COVID-19 pandemic. And it's led by an assistant professor of emergency medicine and pediatrics in New York. This second project here, 1918 flu pandemic and nurse registration in Philadelphia. This project brings together faculty in the University of Pennsylvania School of Nursing, as well as trained historians to explore how the history of nursing can guide the development of a national system to increase the availability of specially trained nurses to meet pandemic needs. And this too was a really notable feature of the crisis in the United States, that there was inadequate staffing availability. So we ended up having situations where traveling nurses would be moving from one site of outbreak to the next, as you know, a particular city would have a terrible outbreak of COVID, and then as that would start to calm down a little bit, there would be an outbreak in another part of the country, and people would literally have to just be traveling around to these different sites because there were not enough trained nurses in those locations to handle the scale of demand. Here are two projects based in Germany. A project based in Marburg looked at scientific transcriptions of COVID-19 into animal models, and they're looking at the role of and representation of animals as ways of understanding disease and the historical and cultural and ethical associations and implications of using models to understand how this disease has evolved and how that shapes the ways that we think about the human dimensions of the outbreak. In addition, there's a project on the bottom here, Feeling News, that's based in the Max Planck Institute for Human Development in Berlin, which looked at how the history of emotions can inform analysis of the news during times of crisis. And in fact, Germany has been an important model as we have developed this work on translational humanities for public health, as the German government, in contrast to the US government, especially in the first couple years of the pandemic, played a notable role in enlisting humanities scholars, among others, to work on research aimed at developing policies to end the coronavirus lockdown in a comprehensive, ethical, and equitable way. And this is from a piece in Times Higher Education that described how Germany had enlisted the advice of philosophers, historians of science, theologians, and jurists. So in other words, not just scientists, as it navigated the delicate ethical balancing act of reopening society while safeguarding the health of the public. And this was from, this may be familiar to you, a Leopoldina report that drew on humanities expertise, including that of the director of the Max Planck Institute for the History of Science, as well as a number of other contributors. And as I saw the ways that researchers in medicine and the humanities were working together to address the challenges of the COVID pandemic, I was inspired to write a piece called Calling the Humanities Essential Services back in May of 2020. And in that piece, I argued that this pandemic has made the human fragility of our response infrastructure abundantly clear. And we need to understand how our decisions about whose life matters will shape the future to come. I was inspired in this piece to talk about the humanities as essential services because, again, I was noticing the ways in which science and technology were being employed to respond to the crisis that was upon us. But in doing so, through that lens, we missed out on a lot of the human experiences and the human suffering that was actually going on in the pandemic, which over time has become more and more apparent. And this perspective is very much one that characterizes a lot of work in medical humanities, the idea of looking beyond what is purely scientific in medicine and understanding the role of history and ethics and culture and society, as well as arts and literature in shaping how we define what is health and what is disease, what is illness and what is healing, and many other things in that context. And I'll be happy to talk about that more in the question and answer period if you would like. So when we consider new challenges beyond the COVID pandemic, such as restrictions on women's reproductive rights, gun violence, and other societal issues in the United States, we can see that the kinds of connective, cross-disciplinary, and cross-sector approaches that are grounded in local community interests and that are led by community members have the greatest chance of making a powerful impact. This means looking at these complex problems through multiple lenses. So reproductive rights for women is a medical issue, but it is also a gender and racial equity issue. It is an educational issue and an ethical issue, and among others. The same is true for gun violence. And broadly, I would argue that we really need to bring methods from the humanities and the social and natural sciences together to avoid the kinds of siloed thinking that result in narrow solutions that only address one specific aspect of a problem and don't really recognize the broader social consequences of many of these large-scale crises that we are experiencing. So I like to refer back sometimes to this report that came out in 2018 from the National Academies of Sciences, Engineering, and Medicine in the United States, which was called The Integration of the Humanities and Arts with Sciences, Engineering, and Medicine in Higher Education, Branches from the Same Tree. And in that report, they argued that approaches that integrate the humanities and arts with STEM fields are associated with increased critical thinking abilities, higher order thinking, and deeper learning, content mastery, problem solving, teamwork and communication skills, improved visuospatial reasoning, and greater engagement and enjoyment of learning. This report was arguing that that education in the sciences, engineering, and medicine had moved too far away from its original roots that were much more connected to the arts and the humanities, and that bifurcation was decreasing the power of STEM education and also making it less capable of responding to the complex crises that were facing humanity worldwide. And this was, of course, written before the pandemic. But when I look at this now, I ask myself, which of these skills that they describe here is not needed in the pandemic response? And clearly, they all are needed. And this is further reinforcement, in my view, of the need to reintegrate these approaches as we address these complex problems. So the kinds of cross-disciplinary collaborations that have emerged during the pandemic do give me hope that we will be able to work across sectors to anticipate challenges and build trust and equity into health innovations when the next wave of crisis hits. When we face complex intersecting challenges like global pandemics and climate change, we need a collaborative response that transcends disciplinary boundaries and offers novel approaches to vexing problems. I believe that the international exchange of ideas, such as the one that we're having today, is a strong step in that direction, and I'm honored to be part of it. Thank you.
Wow, thank you very much for this most interesting talk. I have a lot of questions, but I'll just ask one, and then perhaps I can ask the audience to step in.
Sure.
Towards the end of your talk now, you talked about science and the public. And I asked myself, how can the humanities address the friction, which was also so visible in Germany, and I seem to remember also in America, how can the humanities address the friction between science and the public? With friction, I mean that the public brings an incredible pressure on science to provide final answers without any ambiguity. I mean, you talked about ambiguity and uncertainty in public health.
Right.
I mean,
right.
the process of scientific research and learning in the COVID process was always, or has always been changing very fast. And there was always an element of uncertainty and ambiguity. the responses of the governments, also in Germany, were quite erratic or appeared to be erratic at times, mm-hmm. but they just responded to new research, yes. and the public just didn't understand or didn't want to understand what was going on, and they did not go for ambiguity and uncertainty. They wanted final answers, and mm-hmm. There was a lot of attacks, a lot of friction on individual scientists, because they changed their views ever so slightly at times. And mm-hmm. how can the humanities react to that?
Well, yeah, the situation was very similar here. I think there was a similar kind of difficulty in figuring out on the part of scientists and of government organizations that were trying to communicate science, how to do so when knowledge was transforming constantly, right? And where we were in fact seeing science in action in a way that we don't usually see science as a general public until kind of the process is somewhat complete, say. And I think there are several ways that the humanities can help with this. One is through drawing on research in media studies and in communication studies that understand the current environment for communications. So, for example, organizations like the World Health Organization were formed in an era where there was centralized broadcast communication, and it was easy to have a top-down messaging strategy. They would have an official declaration about whether, if there was some kind of health emergency, and instructions on what to do that would be sent out through broadcast television and through film, and everyone would get the same message. And even if everyone didn't sort of interpret it the same way, it went out everywhere in the same way. Now, of course, that is not true at all. We have totally decentralized forms of communication through social media and through all of the other ways that we can communicate online, such that an organization like the WHO has to learn from researchers that look at how messages travel through these networks of many to many forms of communication, which is a really different form of power in communication. And it's also a different way of engaging with different communities. It means that there's both an opportunity and truly a requirement to understand the different kinds of sub-communities that are part of these networks of communication. So the form of communication itself is one realm where there is research in the humanities that can inform this dynamic. So that's one level. But then another level is looking at research on understanding culture and the ways that different forms of cultural communication, cultural representation, sort of teach us in a way how to understand the world. So, things like literature, say, or film, or other forms of art don't have to have a clear kind of unambiguous message at the end of them in the way that people expect a scientific communication to have a clear, singular kind of, yes or no sort of message at the end of them. And this is something that medical humanities has long been looking at as something that's needed just in medicine, never mind in the context of a global pandemic, which is that for patients, patients also don't like ambiguity. They want to know, what is wrong with me. They don't want to know it could be this, it could be that. And similarly, patients want to know how they can be cured. They don't want to know this might work, this might not work. But the reality is that medicine is not black and white, and we do not often have one intervention and only one that could be a good choice. Sometimes the best choice is one that is driven by an individual person's religious beliefs, much more so than science, or it's driven by what kind of social community they live in and how they might be able to be taken care of after they have some kind of medical intervention. So there again, you can't just get a singular scientific answer to that. So medical humanities has long looked at narrative as a way of helping both health professionals, doctors and others, as well as patients, come to be more comfortable with the reality that most of medicine is full of ambiguity and uncertainty. And science itself is always a process. It's never over. We're constantly learning new things that then throw other things that we thought we knew into question. And so the reframing of that through, say, literary tools, for example, literary analysis, or just engagement with literature is a way of shifting that focus away from kind of an expectation that is not necessarily something that we expect in all parts of life, but that we've come to expect in certain parts, such as medicine. So it's a way of kind of opening that back up to say, you know, this is actually part of the larger world that we are all a part of, in which there are multiplicities of experience, there are histories that shape what matters and what we make meaning out of in this context. And that is a way of kind of reframing what you were describing as the sort of public expectation, the kind of intolerance for ambiguity. I think that both of these approaches are really needed as ways of just reframing what science can do in the pandemic. But part of that also then is broadening out the frame of sort of who we expect to kind of address these problems, right? So by framing the pandemic as a purely scientific and technological problem, you then set that up to expect a purely scientific and technological solution, right? But if it's framed more broadly, then there's space for more kinds of interventions and more ways of understanding what's happening that allow, I think, for more tolerance of those kinds of uncertainties that we have seen in action over the course of the past 2 years.
Yeah. I mean, probably never before, I mean, this is just speculation, probably never before has the public had the opportunity to follow and to see the evolving findings of science, you know, and this was not a linear movement. This was quite often circular, or in some kind of a dark alleyway, or and the public must understand this. Yes.
Yes.
Yeah.
Yes. But very much.
What about the audience? Please. Don't hesitate. I mean, we are a small group, so no need to raise your hand or something like that. Just barge in, just chime in.
Yes, good evening. My name is Edda Emisch. I would like to ask something too, and to contribute my own experience as a teacher as foreign language of German. I remember a situation when my head of schoolmaster came to me and said, "Oh, you are not wearing a mask. You are teaching without the mask, but you must wear the mask." And I said, "This is not possible, because I rather like opening the window, but I don't want to wear the mask, because the children from other countries who must learn German cannot see my lips, my face, my gestures, my emotions." And when you want to learn German as a foreign language, you must see what people do with the gesture of the face, of the lips, the teeth, everything. And I said, I only can do it without the mask. If you teach in German, a German child that has known the language from the beginning of the life, this is possible. It's not easy for the child to see the teacher without only with the mask, because they said to her, "Oh, you look like that." And then the students were a little bit astonished about the teacher's outlook. And I always showed my naked face and said, "I don't want to wear." And I said to the children, "Take off the mask when you answer and look at me and look at the others." For me, I think it was a very important fact not to hide my face, and for the children too, because what is important to be healthy is also seeing people's faces. For me, it was very, very important. And whenever I could teach without a mask, I did it. And so I think this is what I would like to say to your memory of cultural, of international, of connecting people with other humanities like art and all the things. And I saw that the children expressed their emotions, their feelings in pictures. If they could not speak, they painted pictures. This is, I think, because they suffered a lot from the hiding their faces, their emotions under the conditions of the pandemic. They had to test 3 times a week, and they were afraid of being ill and being tested with the results. And this is, I think we have to be careful only to look at the part of health only for hygienic and all these social distances. I think it's not good. A lot of people suffered a lot, especially elderly people too, and the children, that they could not meet their boyfriends and girlfriends.
We had very similar observations here about teaching languages during the pandemic. And in fact, during the worst times of it, all of the language classes were taught online so that they could remove their masks, and so that all of the students could as well, because they found the exact same thing that you said. You cannot do it if you cannot see the facial expression, the lips moving, all of that stuff. But the other thing that I think that you're talking to is something that I mentioned briefly in this talk, and I've actually spoken and written about it a lot more than I did today, which is the role of trust in the context of the pandemic. And there too, that is something that is difficult to quantify as a scientific output, right? But it absolutely plays into the ways that we think about not only whether people will participate in certain kinds of policies that are made to protect the public, but also in terms of how we even understand what kind of environment could be a healing environment for people who have suffered and been ill, or who have suffered emotionally, mentally, through isolation, all of these things. So that, to me, is one of the components where, you know, you would see, for instance, efforts to use digital contact tracing would fail because different communities just didn't trust what was going to be done with the data, right? And that ranges in different ways from, say, undocumented immigrant communities to Black communities, to Native American communities, or to anti-government communities. And coming from many different perspectives, that issue of trust was very much influencing what they were doing. And so that plays out in relation to government policies, but it also plays out in the context of medicine. And this too is something that is a very strong theme in medical humanities research, which is the question of how it is that the environments that we have created as societies to be healing environments often actually work against healing, because they undermine the trusting relationships that are necessary between doctors and patients, or nurses and patients, or that exclude families, or that exclude cultural forms of expression. And in so doing, actually make medicine into something that is not healing and that is potentially harmful. So that theme of trust and the way that it is conveyed is something that I think is really important, and weaves through many issues relating to COVID as well as before COVID and beyond that.
Okay, any other question or contribution? I mean, at the outset of your talk, you mentioned self-tracking.
Mm-hmm.
And actually, if I wear one of those watches, whatever, and I track my heart rate, or while I sleep or while I run, whatever, I would have access then to the average heart rate, say, of other people, wouldn't I? Because if my own data aren't really worth anything if I don't have the possibility to compare to other data. And,
right. Well,
I mean, in Germany and in Europe in general, and especially in Germany, we have a very highly developed sense of data protection, quite often to the extent of obsessiveness. No? And what about America? Would this be an issue in America? Medical data protection, especially in these self-tracking devices, because you send these data to some kind of a data center?
Yes. I mean, that is a whole other talk I could give, which
I know.
we have given.
This
This is a really big issue because in the United States, there is no general data protection law like there is in the EU. There are laws protecting medical data, but the problem is that medical data is very narrowly defined. So that covers essentially data that might be collected in a hospital or in a traditional medical setting, but it does not cover self-tracking devices. It does not cover anything that you might create on your own outside of medical settings and share with whomever. The question of whether your own data is compared to others or is kind of aggregated in some sense, that varies a lot depending on the device and the, where you might be sending it to. So there are many online communities where people share this data freely with each other. And what often happens with that is that third-party data brokers scrape those sites and they gather that data and they aggregate it and they repackage it and sell it to different entities who want to use it for, it could be for training models for artificial intelligence, it could be for data sets for risk profiling for insurance agencies or for health organizations, for banks, all of these kinds of things. So this is a huge problem that there's a really wide range of attitudes about. Some people just don't care because they like getting the data and they like using it for their own interests about themselves, their health, or whatever it may be. Some people I've heard in many patient communities who, for example, are especially rare disease communities, there are many people who feel that they're less concerned with data privacy than they are with finding some kind of medical intervention that can help them with a problem that thus far no one has been able to help them with. And so they see this as a really legitimate trade-off for them, their privacy for potentially insights, research insights. But then there
might also be some solace in that.
Yes, exactly. There's definitely a kind of social
people with similar sufferings, and you can compare and exchange views and exchange data. Yeah.
Exactly. Yes, that's absolutely true. And then there are also patient communities who found a great deal of value in sharing information with each other, not only social and emotional, but also things like they would find out about clinical trials of drugs or devices that they didn't know about, but other people in the community knew about, or how to manage side effects of certain pharmaceuticals and those kinds of things. And all that was very valuable, but there has been a movement also since essentially it came, the Facebook Cambridge Analytica scandal came to light, that recognition that these big technology companies that are looking to become more involved in healthcare are really exploiting patient data that is being shared on these platforms. And there's a great deal of frustration among these groups because they see so much value in sharing data amongst themselves, yet they recognize that in doing so, they're also sharing it with these companies who don't have their best interests in mind. So it's a huge conflict. And in fact, there are ongoing debates right now about updating the data privacy regulations, especially related to health, that are happening at the US Congress level, and they're in progress. So it is still to be seen where they will land in terms of how much protection, either for individuals or for corporate entities, where that will fall. Usually in the United States, those protections go to corporate entities, not to individuals, in contrast to the EU, where it's kind of more the other way around.
Perhaps a recommendation to the audience, the novel The Circle by Dave Eggers was quite prophetic. And there's also a film, but the novel is just fascinating. Dave Eggers' The Circle. It's quite prophetic in this context. Yeah. If you haven't already read it, do so. It's for the rest of the summer, summer reading. Yeah.
Good recommendation.
Yeah. Yeah. Yes, I mean, are there any other questions, contributions? Oh, if not, let me just thank you, Kirsten, for this marvelous talk. I'm quite overwhelmed with all the facts and the ideas and the complexities that arise out of your talk. I think it was quite fertile, this talk. And I suggest that the audience also listens to it again and goes to our YouTube channel and to listen to it again and gain further insights. Thank you very much. And
Thank you.
Wish you a good afternoon, because it's something like approaching 1 o'clock
That's right.
in Houston. So
that's right.
You still have your day ahead of you whilst we prepare for our dinner.
Yes.
Thanks again. And I seem to remember that I promised to get you in contact with the local CISPA Institute, which also has a program for data protection in medicine. And I'll promise I'll get you in contact with them. This time I'll do it.
Okay, sounds
anyway,
good.
Thanks again very much. Food for thought. Thank you again. Bye bye.
Okay, thank you.
Bye. Thank you.